So I'm going to give you an update on essential tremor, in particular about magnetic resonance guided focused ultrasound. It's a catchy title, but something that we're being asked to comment on and see patients in relation to a little bit more. So the background is that around a quarter to a half of essential tremor patients are refractory to medications, and that would be in particular propranolol, primidone and topiramate. Those are the main players. And in selected patients, we've always been offering brain surgical techniques where appropriate for refractory patients, and really deep brain stimulation has been the main thing that we've been doing over the last 30 years and for about 20 years in Glasgow. And that superseded the classic thalamotomy lesioning. But MR-guided focused ultrasound treatment is the kind of newer kid on the block. It's a non-invasive thalamotomy. It's available around the world. It's now available as standard care in NHS England since this year. And from this year as well, it's available in Tayside for 12 Scottish patients over the next 2 years as an NHS pilot funded by charity donations. There's some uncertainty about ongoing funding after that, and there's still ongoing discussions to be agreed and had with NSD. So what is it? Well, under MR guidance, around 1,000 ultrasound beams are directed towards the thalamus in an awake patient. And initially a test lesion is produced, which is reversible, and that's produced by basically heating the brain up to about 40 to 45 degrees Celsius by low power sonifications. And patients are tested during this. There are various tremor tests, speech tests, to see whether they have paresthesia or ataxia. And once the team are happy, then the lesion will be created by heating the brain up to around 50 to 60 degrees Celsius. And the team is in Tayside. This is Dr. Tom Gilbertson, who's a neurologist, and Mr. Sunny Khan, who's a neurosurgeon. So how does it compare to DBS, which we're all a little bit more familiar with? Well, it appears to be definitely less invasive. Of course, with DBS, you need implantations of all sorts of equipment and leads and batteries. So you need less hospitalisation. There's less likelihood of lead fracturing or a requirement for battery replacements, which usually need to take place every 3 to 5 years or so with DBS. So you have less hospital visits because no programming is required once you've had your treatment. That's basically you up, and it's an outpatient treatment as well. And it probably does have similar efficacy to deep brain stimulation for essential tremor, but the long-term data isn't actually available for it. It's a little bit less certain in MR-focused ultrasound, and in some cases, tremor control might actually degrade over the course of the first year. 3%. It can only be done unilaterally as well, whereas DBS can be bilateral. And if you do it bilaterally, then you're more likely to get dysarthria, dysphagia, and ataxia. And there's also a risk of permanent side effects. So at 1 year, you may get paresthesia in around 14% of patients, and balance issues in around 9%. And that's in comparison to DBS, where although there is a risk of stroke at onset, really other risks over time are reversible because the DBS can be turned off. It's not modifiable as well, so if your tremor worsens over time with DBS, you can increase the amplitude or various other settings, and you just simply can't do that with MR-guided ultrasound. So which patients might benefit from this? So they have to have a diagnosis of refractory essential tremor only. At the moment, the team in Nine Wells is not accepting patients with dystonic tremor or MS tremor or any other type of tremor. It needs to be severe and, of course, refractory. So severe meaning that it's really having a major impact upon activities of daily living, not just causing anxiety. It has to have a really problematic. So as a guide, 2 to 3 centimetre amplitude postural or kinetic tremor. Of course, there needs to be no MR contraindications. They need to have really good balance, speech, cognition, and they generally shouldn't be frail. And they should not want or be ineligible for deep brain stimulation. So we're, as the movement sort of team, happy to discuss or see any patients that you think may be suitable, in particular if they are severe and refractory. So there's not much point in us seeing some of the much milder patients because they're certainly not going to be suitable for surgical management.